these nodules in stomach and stomach more common, and has been proven that these neuroendocrine tumors in the GI tract are rising exponentially, and in fact, in last 30 years, there is a 500% increase in the pickup rate of these neuroendocrine tumors. These incidents are not rare because we are more aware, we have better pathological identification, we have wider use of endoscopy, and of course the PPI use may be associated with this. So the neuroendocrine tumor can involve any part of the body. Most of them are in the digestive system. We as a gastroenterologist deal with them. They can also involve the pulmonary function like trachea, bronchus or lung, and also the gonads. So as a gastroenterologist, we have to deal with this, and the majority of the lesions are in small intestine, and we also find them in stomach, pancreas, appendix, and duodenum also. If you are working in a very high volume center and a center which has good, the backup of many specialists to treat this, your outcome is going to be very good. But if you are having very less number of experience on this, the patient may not do good. So one must be aware of these neuroendocrine tumor in the GI tract. How should we manage? If we see such things in our routine endoscopy, we must know. So the cell from where these neuroendocrine cells arise are ECL cell, either they can be histamine secreting or serotonin secreting. So these gastrointestinal neuroendocrine tumors are either called carcinoids or NETs. They can be gastrin dependent or gastrin independent. So this is very important. So once you see the neuroendocrine tumor, you take biopsy and then decide whether you are dealing with less aggressive tumors like G1, which has got mitotic index of less than 2 or Ki index of less than 3, versus poorly differentiated. These are very aggressive tumors which have got cellular polymorphism, and also the Ki index is very high, more than 20%. So we must know the organ of origin and the histopathology, whether we are dealing with G1, G2 or G3 tumors. So the diagnostic workup starts with staging, like the depth of infiltration, lymph node metastasis, that all determine the prognosis. So as soon as I see a gastric nodule, what I do is I see the gastrin. So if gastrin is high, that means these nodules in the stomach are being gastrin driven. Now, what happens is when there is a chlorhydria or less than pH is less, there is secondary hypergastrinemia leading to type 1 carcinoids, which I will show you how you see type 1 carcinoid. So whenever you see a stomach nodules, divide them, whether you are dealing with type 1, type 2 or type 3. Type 1 are associated with atrophic gastritis, corpus predominant, leading to achlorhydria and high gastrin secretions. The second method of high gastrin secretion is if there is a tumor, like Zollinger-Ellison syndrome, when the tumor is being secreting a gastrin, which is causing these nodules to appear, and in this case, achlorhydria will not be there. In fact, there will be very low pH, and then these can be diagnosed as type 2 gastric carcinoid, which are associated with Zollinger-Ellison syndrome. But if you find the lesions are very big, like more than 2 centimeter, infiltrating into muscularis mucosa, there is angio invasion, or when you take biopsy, it is G3, you better predict that there can be metastasis and they may require more advanced imaging like DOTA scan or PET scan to know whether metastasis is there or not. So first thing which I do is endosono to decide which layer are arising from. Mostly they are hypoechoic and they arise from second layer or deep superficial submucosa. So this is the organ of origin of neuroendocrine tumor. And this is a typical endoscopy which I am doing to see endoscopy. The mucosa looks atrophic here, and then you have multiple such nodules. So this is a typical of autoimmune gastritis leading to corpus predominant atrophy, leading to hypergastrinemia, and leading to formation of these nodules. You can see once you do a magnification endoscopy in gastric corpus, you will find atrophic. So there is no collecting venules, there is no subepithelial capillary network, and this has been replaced by atrophic mucosa. So the background mucosa is showing atrophy, and then there are completely full of these nodules. So this is typical of type 1 gastrinomas. So these type 1 gastrinomas, as I said, are associated with high gastrin. So if you see a gastric nodules, do a gastrin. If high gastrin, see whether the pH is low or high, or if there is atrophy or no. If there is pH of the gastric juice is high, that means alkaline, that means echlorhydria, you decide it's type 1. Type 1 are 70 to 85%. They are multiple, polypoidal, multicentric. They good prognosis. Prognosis is very good. You may not to remove all. I'll come to that. While type 2 gastrinoma, again, you will see high gastrin, but pH will be low because there is a tumor which is secreting the gastrin, and this is known as Zollinger-Ellison syndrome or MEN. While the tumor, if you find such tumor and the gastrin is normal, then it is a problem because these are rare and these are type 3 gastrinomas. Type 3 gastrinomas are more aggressive, they have got metastasis more than 50% at the time of diagnosis as compared to 2 to 5% in type 1. So majority of the cases are type 1 with good prognosis, while type 2, one must recognize them early with normal gastrin and should be referred for predominantly surgery, but we'll talk about that. There are no newer endoscopic treatment available. So type 1 majority are treated by EMR, and if they are more than 2 centimeter or they are muscular valve infiltration, they may require surgery. Other treatments like somatostatin, cytostatics, gastrin receptor antagonist are not considered in type 1, but may be considered in type 3 when you are not able to remove them endoscopically or surgically. So this is a typical of type 1 gastrinoma. Again, all are less than 1 centimeter. We are seen by endosono. You can see that tumor is arising from submucosa, muscle layer is intact. That means this patient is fit for ESD, and you can do a simple ESD and remove these tumors completely. So more than 2 centimeter you have removed by ESD, while the less than 1 centimeter, either you can follow them because the metastatic potential is so low that you may not require to do anything, but if required, you may do a procedure known as banding. You can see once we have removed this big tumor, you can band these small gastric nodules and leave them alone. So this is, they cause ischemic necrosis, and these small gastrinomas, gastric carcinoid falls down. So, but everything which can be removed should be removed. It's not like that. Type 1 gastrinomas are very good prognosis. Their survival rate is around 78 to 100%, which is not different from general population. Only those which are more than 1 to 2 centimeter also have low-grade malignant potential, low lymph node metastasis. So even if they are G1, they behave in a benign method, but if the lesion is growing in size, you may consider endoscopic resection. But even if you do endoscopic resection, there can be local recurrence. So it's important to consider the size and the histological grade. Like if they are G1, G2, small, you can treat by ESD, EMR, or full thickness resection. While if they are too big, they can be sent for wedge resections. Or the tumor histology is G3, again they go for surgery. But if tumor histology is G1 and G2, even if they are large, they can still be removed endoscopically. So it's important to consider the size and the tumor aggressiveness by initial biopsy. So these are some of the indications of surgery which I already talked about. The type 2 gastric neuroendocrine tumors are again hypergastrinemia, but they are associated with MEN syndrome. Their behavior is between type 1 and type 3. So majority of the time their prognosis depends on the MEN1 rather than the tumor. So tumor will definitely can be removed, but again they behave same as type 1. And these are the type 3 gastrinomas, solitary